Thank you very much for the opportunity to talk. I wasn't really giving a full presentation, but just some talking points to engender discussion. Really the question was, there have been a number of people in what we might call the respiratory protection community who have been involved in addressing questions concerning respirators, respirator use, and it was to give a quick overview of what sort of questions we've been asked, and perhaps to answer questions from WHWB members as well. And Marianne mentioned the ISRP, International Society for Respiratory Protection. So this is an organization that has been established since 1982. The primary focus, of course, is to engender education and information sharing in the field of respiratory protection. Membership from around the world, and we have a peer-reviewed journal, and it's a technical journal on aspects around respirators use and testing. And then we have conferences every 2 years. Next one, we hope, will be in Oxford, England in September this year. So that's last one was in Denver. And there's a website, as you can see, and there are abstracts from the journal and from the conference available as well, if you want to go and search through that. So that's information there. So just a bit about that. On to the sort of questions we've been facing and the sort of issues that seem to be very current in respiratory protection. And we can't avoid it now because it's on the news every night or every hour. These are the points, as a group, we've been having to deal with. I should mention my own career has been with mostly respirator research and development into the solvent materials that go in for gas and vapor removal, first of all, and then into respirator design. And for about the last 15 years, I've been involved in standards development, the Canadian Standards Association, and with ISO. And so I've had a career partly involved in materials that go into filters, partly in filter design, and have finished my career in Canada, in Brockville, Ontario, in Eastern Canada, the manufacturing plant and research laboratory. And a lot of the time there was spent in mostly powered air purifying respirator filter designs, the higher end of the end market. And then, so I've been working with CSA and ISO latterly. And so just retired, early retirement back in last September, but I've kept active with ISRP, American Nursing Hygiene Association, and with the standards committees. So some of the questions we've been looking at have been regarding respirator use as they are routinely used in hospitals, but the question, of course, with a shortage of supply dominating issues right now. So some of the practical issues first, and then I'll get onto some of the more technical issues that are behind those practical issues. First question is really on extended use of respirators. And this is, rather than changing a respirator regularly, can one use a respirator longer between patients if you're in a healthcare facility or for a fuller part of the working shift, and not changing when normal to avoid perhaps cross-infection, or even to avoid discomfort when the respirator becomes hot or moist. And so that's one area, and I'm not going to get into all the details of each of these, perhaps run through these quickly first, and then we can discuss those that are of interest. This is one of them, and we're hearing about, again, with shortage, workers are being asked to extend to using just 2 respirators a day rather than changing frequently. Next one has been a reuse of respirators, and that is rather than wearing longer, this is taking it off and putting it on again repeatedly. Can one use the same respirator on and off without decontamination? And how can one decontaminate a respirator? And so there's been extensive discussion on decontamination methods, and I had a few of them here that have been coming up. So I might say one technique is no decontamination. These respirators are just hung up and left to sit overnight, say, the assumption being that any contamination on them in some forms of a virus will be deactivated by the time they're reworn. Other modes of decontamination have been simple heat, And of course, there is a question with each of these as to what is happening to the respirator in this treatment. Steam, and that may be just steam from a steam source, and sometimes steam generated by microwave treatment. Ultraviolet light has been mooted, again, as a decontamination method. Some pluses and minuses with that. Of course, it can't reach areas in shadow, and the question again of what it might do to degrade a product. And I'll get into some of those failure modes in a minute. And then there are questions on chemical decontamination and using different gases to sterilizing gases to again attempt to remove any living material that's being retained on a respirator. And hydrogen peroxide vapor or plasma has been mooted, and that is something that has been explored, and there have been some publications, presentations on that, and that's being promoted by CDC right now as one method. But again, it's something that's not widely available. There are some small peroxide decontamination systems in hospitals, but they would not be amenable to large-scale use, large volume use for decontaminating products. There are agencies now that may take your use filters and decontaminate them, or set up a mobile facility that can visit. Ethylene oxide, ETO, has also been mooted. That's perhaps not a good plan. It's a highly toxic gas, and the question, of course, in this chemical decontamination remains as to how much chemical may be retained on the respirator, and you don't want to cause a health hazard from that. And again, apologize, I'm going fairly fast through this, but those are some of the things that we've been discussing. There are various groups looking at reviewing these methods and looking at the studies that have been undertaken to determine if recommendations that are being made now are supported by science. There's another factor coming into addressing shortages is the utility of stockpiles, that is taking respirators from stockpiles that may have been kept beyond their shelf life. And there have been studies again outside of the crisis and some underway now looking at the condition of respirators that have been stored for many, many years. And also, if I was considering the failure modes that might be observed, these are things that are looked for also after decontamination. What has been found in studies that it's generally the issue with failure of respirators is not the filter capability, it's the straps. And as one's familiar with the filtering facepiece, the typical FFP2 in Europe, similar in Australia, and N95 type in North America, they have elastic straps that hold a cup-shaped filtering element to the face. And both the strength of the straps that they may break and their elasticity, which of course, if it's lost, they don't fit adequately. Both are issues that may occur as degradation in long-term storage or by some decontamination methods. Next factors that are observed for failure are the nose clip. Many of these have a metal, sometimes plastic nose clip that molds the filter to the face. That is in some cases becoming disconnected, and in some versions there is a nose cushion, a bit of foam on the inside, again to improve fit and comfort and seal, and that can degrade materially. It can fall apart or become sticky in some cases. And the last thing, and very rarely is there any failure actually in the filtering element. These have been subject to very intensive research and development over the years and tend to be very robust. They do stand decontamination well, and they tend to stand aging well. So there may be some failures, but that's the lowest cause. And it's possible, of course, to test the filter effectiveness in laboratories. So again, we're investigating, or there's a lot of investigation of the use of stockpiles, and what has been found has been something that's generally fairly easy to check for. Then questions we're getting around our alternative types of respirator. We are familiar, I'm sorry, I put up some pictures, but I think everyone's familiar with the types of respirator used in the healthcare, the filtering facepiece type respirator. And the majority of use, surgical masks, are used also, and we can discuss in a minute the sort of different levels of effectiveness, but filtering face pieces are the common type. But in the time of shortage, there has been the question then, can we use other types of product? First of all, there are filtering face piece type respirators that are designed for industry use. And in industry, because one may encounter oil mist, and there's actually an effective oil mist on the filtering element in some types of respirator, there's a different test and a different standard for oil mist resistant respirators. And so often in industry, they're generally a higher efficiency, but there is nothing that prevents them being used in healthcare if they are available. So that's one thing. And then the question of elastomeric respirators, that is a rubber face piece with filters attached. And that is one that then, again, offers an opportunity. The filters are changeable without having to dispose of the whole respirator. The question with those then arises, of course, is decontamination, because they're more convoluted, there's more parts to them, and so what are the best methods for decontamination of that kind of respirator? But certainly in terms of protection to the wearer, they are no less protective than the filtering face piece type that people are familiar with. And in fact, in most cases, they are more protective. And these elastomeric respirators can come in a half mask type, which do not cover the eyes, they just cover the nose and mouth, and a full face type where there is a visor, a seal right around the front of the face, and a visor that also protects the eyes. And sometimes they come with one filter that screws in, sometimes there's two filters either side that just have a bayonet type connection. And you tend to find different types in different parts of the world, but that's a model that is available. And then there are powered air purifying respirators. And these are systems where there's a blower that's belt mounted, with filters on it, and drives air up through a hose to a head top, which can be loose fitting where it doesn't seal tightly against the face, or tight fitting where there is a tight seal against the face. The air driven by the blower creates an overpressure inside the head top, and so that there's general exit of air from the head area, which of course provides a level of protection that's higher than you rely on when you are using your breath to pull air through the filter. Sometimes these are called positive pressure respirators as opposed to negative pressure, which is the one where the lungs do the work. Again, these are widely used in industry, some usage in healthcare, and there are certain institutions that have studied these and found them very effective indeed in healthcare. But there are also some other aspects to them, their use in healthcare, in terms of the interference with the use of other equipment, stethoscopes and things, or the ability to see the face and have the wearer when they're covered by a hood. So that's questions there, but they do offer a good level of protection, and we might consider their use in certain types of operations, and I'll get into that in a minute. And then the question that now is, say, fairly prevalent, of the use of less effective alternatives than a standard respirator. And this is where the logical protocols you might look at for protection, and we get into sort of the assessment of the needs in this area in a minute, but would suggest that you need a standard respirator which offers a good fit to the face and a high level of fit, to a surgical mask which does not seal well against the face and may protect against direct splash, may perform its task as intended of protecting a patient from a doctor's exhalation or a wearer's exhalation, but it does not necessarily provide good filtration. And if you want some amusement, I can show you a fit test I did on a surgical mask where it's about as good as putting your hand over your mouth. They're not effective at filtering the inhaled air. But again, in times of shortage, we get into the question of better than nothing. Is having something protective better than having that's not as effective as what you should be wearing, better than nothing or not? And that also applies to homemade alternatives that we're seeing a lot in the news right now, cloth-type respirators or things made from various items you can buy in a drugstore. And whether, again, they offer adequate filtration, it's probably very much at the low end of things, and whether they are better than nothing. Because the problem with having something worn is that people tend to think it gives them protection when it may not. And so they may put themselves into a more risky environment or undertake a more risky procedure than they otherwise should, based on the protection that they're getting. So again, these are points that, as I described, this is one of the strong points of discussion right now as to what is the thing to do here. But certainly, one would have to say that using scarves and things like that are going to give you extremely little protection. They might stop people touching their faces, which is perhaps a good thing. They might stop people exhaling too many droplets. But again, it's a question of they're not giving protection that people might anticipate they do. So those are some of the sort of practical issues I think as a group we've been looking at, and I haven't gone into detail on any of these, but that's the state there. So on the technical side, this is sort of the underlying science and technologies that goes behind some of these issues. A big question that is again behind advice that is being given to healthcare and to the public is around the mode of dispersion of infectious aerosols. That is, how are these viruses we're dealing with, in this case, transmitted from person to person? And this really has an impact into respirator selection, what you need, of course, in terms of a respirator to be protected, and in those distancing requirements. We hear the 6'2" rule stated a lot, and where that comes from. And I'm sorry to say, I think it probably will be consensus among those who are really studying this sort of thing that there is some difference between what the infection control training and the infection control community might assess in this area and what occupational hygiene might assess. And we've been dealing with this for a long time. And so, and I see, actually was talking with Margaret Seatsman and Lisa Brosseau, a retired scientist from University of Illinois Chicago, has done some excellent review papers on this. That there is I guess, science, you might say, that's behind traditional infection control training is fairly old, 70 plus years old. We're dealing with a consideration for infection control where it tends to be in the things are in buckets or in black and white. You have contact, droplets, and airborne precautions, and that determines the type of PPE that you need to deal with patients who are infected with that particular disease. When you look at the aerosol physics and sort of the occupational health and safety background, it's far less black and white. It's much more a spectrum. There's a steady gradation of droplet sizes that might be expelled, say, in talking, coughing, sneezing. And there's been studies on these. There's then the issues that droplets that are expelled evaporate and change size and may become more buoyant than expected. Sometimes, say, taking a standard 5 micron cutoff between droplets and airborne, it's been shown that particles larger than 5 micron can be quite buoyant and some less can fall out readily. So that's these sort of hard and sharp definitions actually do not tend to be as hard and sharp when examined. And so there's even been studies of where they've done sort of simulated coughing and found that something like the size of a patient room in a hospital will fill with aerosol in 5 minutes, no matter how far away you're standing from a patient. And so it comes to arguments over viability of the virus as well over this time, and how much will be expelled due to where it is in the respiratory system of these infected individuals. So there's a lot going into this, and of course it can vary from disease to disease, even from types of influenza to types of influenza has been observed in the past. So there's a lot of research needed there, and sort of making hard-cut assumptions or rulings, as it were, that have been made so far may not be the safest thing to do. It may be wise to be more cautious and assume that not always something that is considered droplet is always falling out of the air within 6 feet, because it may not necessarily be so. And also there are other issues that may arise, say it may be droplet coming out of the person or in that range, but if you have a toilet flush or an infected material, then that can create an aerosol in the air and you can still have infection that way. So it's particularly in developing standards where I've been involved, we have been trying to move on to the more cautious side of things and advise always to have proper respiratory protection when dealing with infectious material, rather than relying on things like surgical masks or barriers for healthcare workers. So that therefore goes into the respirator selection and how you assess what type of respirator is needed and whether one is needed at all, and those distancing requirements. So just a bit of caution there. Of course, when it comes to dealing with the public and the community at large, you want simple rules rather than having to say, well, it's a bit vague kind of thing. So what's come out, I guess, is safe, but it may not be safe enough in every circumstance in a healthcare environment, put it that way. So it does come to the next question on you might say the effectiveness or the efficiency of the protection required in circumstances in healthcare. What is necessary in terms of a protection factor of keeping the materials out, and that relates to two things when respirators are considered. One is the efficiency of the filtering media that's in the respirator, and other factors like its ability to withstand a splash and that sort of thing. And then, of course, the effectiveness of the fit to the wearer's face or the protection that's offered overall. Because however efficient a filter is, if there's leakage around the filter for any reason, that of course renders it totally inefficient in terms of protection. One might observe that in many areas there has been a focus on the filter material. For instance, NIOSH, National Institute for Occupational Safety and Health, that in the US undertakes set standards, but also undertakes the testing and approval of respirators. And that is the body that came up with the classification that includes N95, that is now, instead of being recognized as a sort of a test method almost, has now become used to name a product. That looks that N95% is the efficiency of the filter medium against a salt aerosol. It's in their protocols at the moment, they do not examine the fit to the face. There are other requirements, and they do a lot of research in that area, but actually the test standard does not say that they have to prove how well a respirator fits to the face. Many other test standards in the world, European and Australian and so on, they do undertake a fit test as part of the approvals protocol. And determine that the design of that respirator will be fitted to be approved. But NIOSH doesn't. So there's this focus on the media that's in the filter rather than the actual capability of it to protect overall. So to say both of those factors are necessary. I will say one thing too, and perhaps I should have mentioned this earlier. In terms of filtering biological materials versus inorganic dusts and so on, a lot of research again has been undertaken on the differences here. And the science has shown, to put it bluntly, a particle is a particle is a particle. That a biological particle does not have any different kind of mechanism of passing through a filter than, say, a salt particle. Bugs don't grow legs and kind of crawl through filters when they're not in use and things like that. That has been actually seriously said by some people, but they don't. So when it comes to the testing of filters, generally for the N95 type and for the equivalents in other standards domains, salt aerosol is used of a particular particle size. And again, we can get into long discussion on this, and I apologize if people are familiar with this, but just to mention that there are different mechanisms of filtration that make filters effective. And again, according to the particle size, you're looking at sizes from tenths of a micron up to many microns. Some of these filtering mechanisms, when it comes to the interaction of a particle with the fiber in a filter, some of these are more effective at large size. Some are more effective at small size because they're getting into electrostatic interactions that work actually better on smaller particles. And so there is not a T-strainer effect, not a cutoff inefficiency with the filter like you might consider on a gross scale. In fact, if you had a plot, and say I have all this I can talk about, but I wasn't getting a big presentation, but an efficiency, percent efficiency, say, versus particle size plot, it's kind of almost a straight line, but with a dip in the middle, a sort of an upside down bell curve almost at one point. doesn't go down to zero, it just goes down to a minimum. And that is the most penetrating particle size. And for the types of media and sort of conditions, flow rate and so on, one is encountering in use of respirators, that's around between 0.2 and 0.3 microns. And that is the particle size that's used for testing. And when it comes to something like an N95 or an FFP2, the 95 is 95% efficient at that particle size. And it's more efficient for smaller or bigger particles. And so when we come to consider the sort of particles one is encountering, in transmission of disease, they're generally larger, and so the efficiency is pretty well close to 100%, even for what is ostensibly an N95 type filter. That's why they're safe to use in these circumstances. You hear arguments about, well, viruses are so small they'll get through. Well, no, first of all, the forces on them are going to attract the viruses to the fibers and retain them well. And also viruses don't tend to be free in the air. They tend to be associated with some, usually a droplet, sometimes on the surface they've attached to, so that they are readily filtered. And so there's no issues really around concerns about leakage through filters due to the media, unless it's been compromised in some way, with a filtering facepiece or other kinds of respirator. Much more concern about how well the product fits. And again, you've got fit testing that's undertaken. And I know certainly North America, there's been a very strong emphasis on bringing fit testing into hospitals and healthcare facilities since the SARS outbreak. And so that's improved the level of respiratory protection in those environments. And so that's the key area of focus. And if one is wearing a filtering facepiece under the sort of typical protocols that apply, where you're seeking for industry a protection factor of 10, a sign protection factor of 10 is all those things are assumed to have due to their design. But when you look at how it must fit, you actually seek a value of 100. Give yourself a 10 times buffer to account for how it may change during the working day in terms of fit on the face, so that you have, again, very good protection from those. And then we talk the full face respirators and powered epirephrine respirators, they go up from that value. Sorry, a bit of a rant about respirators, but to say we do see the need for respiratory protection, and there's good science that's gone into knowing that filters will do the job and the ways they are tested and to make sure they do. And that then comes to selection guidance. It all sort of mixes into that, and how you might advise on what sort of respirator to use in what circumstances.